is the natural history of DCIS if left untreated? So if you look at SEER data from the past 2 decades, patients with DCIS who did not have surgery, 11% developed invasive cancer on the ipsilateral side, so about 1% per year. 4% at 10 years developed a contralateral event. So again, this is showing that DCIS is a marker for breast cancer risk because bilateral breast cancer occurs, and 24% died from other causes. And so without surgery, the risk of cancer is about 1% per year. And then even if you do surgery, if we look at trials for omission of RT for low-risk patients, the risk of developing invasive breast cancer is kind of similar, 0.5 to 1% per year. Many of these women develop contralateral breast cancer, again, because it's a risk factor for developing breast cancer. It can happen on either side. And so DCIS is a marker of breast cancer risk. It itself is not cancer. And this is the same risk as ADH or CIS, about 1 to 2% per year, but we don't tell these patients they have breast cancer. These are all risk factors for developing breast cancer. So you can think of this as a speedometer. The speedometer is just a marker of how fast the car is going. That's what I would argue that ADH and LCIS and DCIS kind of fit into this category. And removing the speedometer does not change the speed of the car. So removing it, irradiating it, giving it pills, it will not change the risk of dying because it's a risk factor. And do we have any data to support that? Well, here's a study where they removed the speedometer, or they didn't. And so patients who had surgery versus not, the disease-specific survival in these patients with low-grade DCIS was the same. But some patients do die of breast cancer, and Dr. Narod has shown us in 2 prior publications with SEER data that the risk of dying of breast cancer versus the general population, it is higher. But this is to be expected. DCIS is a risk factor for developing breast cancer. Some who develop breast cancer will die of it. 4% of DCIS are actually invasive cancer if you look at inter-observer variability among pathologists. A focus of invasion may have been missed in the specimen. And the cause of death is unreliable in cancer registry data. We call this sticky diagnosis bias. And so is there a better way to look at survival? So if you look at relative survival, this avoids the incorrect adjudication of death in registry data, such as sticky diagnosis bias or slippery linkage bias. It compares the survival of cancer population to a similar population without that cancer, matched for age, race, sex, and time period. So you compare 2 groups, one has DCIS, one doesn't. What's the survival? You look at the 2. And if you do that with women under 40, women who aren't going for screening, the disease-specific survival is rather good, 98%, and the relative survival is the same, and you would expect that. You know, it seems better not to have DCIS, right? So that makes sense. But then something strange happens when we look at the women over 40. The relative survival is 104%. How can they be? They actually live longer than women without DCIS. And that's due to diagnosis of indolent tumors in healthier and more health-conscious women, the women who are going for mammograms. So I think carcinoma should be removed from the name. What should we call it? I think we should call it DIN. I think I heard someone earlier today talking about this. Neoplasia does not exclude the possibility that some DINs may be precursors of invasive cancer. It eliminates the problem of the cancer-non-cancer diagnosis. So when a pathologist, they don't always agree. 10 to 20% of the time, one pathologist will call it ADH and the other will call it DCIS, and this results in radically different treatment for the patient. And removing carcinoma may decrease overtreatment, anxiety, and emotional stress. And we do this for other cancers. Cervical cancer, carcinoma in situ was renamed SIN in 1988. A variant of papillary thyroid cancer, we renamed the non-invasive NIFP in 2015. Other organs as well, we use this terminology. And all of these entities show that you have a higher risk of developing cancer, but they're not called cancer, and they're not treated as cancer. Or could we rename them IDLE, as Dr. Esserman has suggested, indolent lesions of epithelial origin? Can we be IDLE with IDLEs? If there are indolent invasive cancers that can be successfully treated upon diagnosis, then certainly there would not be any value to finding and treating the precursors of these indolent invasive cancers. And so people say, well, what are you talking about? I mean, it's just a quick lumpectomy. What's the big deal? It's done under local with sedation. It's not a big deal. Well, if you're a surgeon, you know that's really not true. So many of these patients undergo mastectomy. Many do this. They want a bilateral with a deep flap reconstruction. There was one plastic surgeon, it took him 24 hours to do it. I mean, that's a lot of time on the OR table. Many of these women go on to get radiation, hormones, psychological distress or depression, which we shouldn't dismiss. Many suffer complications from the surgery or from the radiation. There's healthcare costs to consider, financial costs to the patient. Because when you call it cancer, you're going to treat it as an aggressive cancer. Either doctors will do it or patients will demand it. And we have to ask ourselves at the end of the day, if you do a surgery like this, am I helping this patient live longer or live better? Because those should be our two goals in oncology. And so the whole world's asking this question, is DCIS cancer? Or is it something that we could wait and then watch it carefully and intervene when necessary? So various prospective trials are going on around the world, looking at surgery versus watchful waiting. So I think DCIS is fascinating and it's important, but it's not cancer. It doesn't meet the clinical definition of cancer or the laboratory definition. Overdiagnosis is occurring with screening. It does not portend a shorter lifespan for women over 40. Most DCIS will not progress to invasive cancer. And the punishment should fit the crime. If invasive cancer develops, we can treat it then. We do this for thyroid cancer up to 2 centimeters in size. Patients can undergo active surveillance as a standard of care, and for prostate cancer. So DCIS, ADH, and LCIS, they're risk factors for developing cancer. They're speedometers, they're not engines. I think we should rename it DIN. This would fix the pathologic variability. It would better reflect its behavior, and it would help mitigate overtreatment. So I want to quote my opponent, Dr. Narod, who told the New York Times in 2015, I think the best way to treat DCIS is to do nothing. I think he's right in the immediate period, and we'll see how Lord and Loris pan out to see if this is true. So I want to thank my mentors. These are all people who have helped me think about overdiagnosis and overtreatment in another way, and they've been very helpful to me. And a fun fact about me, I am in the Museum of Modern Art, so if you ever go there, that's me. But I don't think it's up on display right now. Thank you so much.
All right, that is a great way to start us off. So Dr. Narod, come up and make your case and defend your honor with that last quote.
Well, I got a